The state of diabetes in a nutshell is horrible in the United States. We know with type 1 diabetes, less than 30% of people hit their recommended ADA targets. And we know with type 2 diabetes, the epidemic has not slowed down one iota. As a matter of fact, it's still on a hockey stick curve up. In the United States, we treat symptoms and we do so as cheaply as possible. We don't take care of the whole person. And despite spending almost double per capita on healthcare than most other developed countries, our outcomes are mediocre at best.
Many of our patients with the greatest needs have the greatest difficulty coming to face-to-face visits. So our ability to temporarily use remote diabetes educators from Cecilia Health, thanks to a grant from the Helmsley Charitable Trust, was the most precious gift, really. I mean, these educators were able to remotely help our patients in many critical ways. Since starting to work with Cecilia Health, we've referred, I believe, close to 1,000 patients now, the vast majority who were able to connect and were able to benefit from this. So it's really clear to me that remote visits with educators and providers working as a team can really be effective and much more efficient, and really can give us the potential to help many more people with diabetes achieve their goals. And of course, that would reduce morbidity and mortality.
That's really powerful.
Been on a long journey with Cecilia Health to understand our membership better. And Cecilia Health is a provider for us. I don't even consider them a vendor. And what we learned is that early on that we could impact A1C with Cecilia Health, and we showed that twice. So that's just true.
Doctors want the patients to follow their care plan. Well, how does that work? And they really need a personalized, trusted engagement with a diabetes educator, a clinician who's a nurse, a dietitian, a pharmacist that really understands the complexities of diabetes that we've been talking about. And in addition, really understands the diabetes tech.
Where you live dictates whether you have access to specialists and specialty care. In today's day and age, the technology clearly exists to change all of that. Everybody knows in the diabetes clinics, the heavy lifting is done by the certified diabetes educator. So, David's model of the certified diabetes educator being the key and being front and center really was aligned with our vision. And what COVID has done is COVID has really given us an on-ramp to where we were going anyway. But I've heard this expression, we shouldn't let a good pandemic go to waste. Now is the opportunity to seize on what is changing before us for the better in the midst of all of this craziness. And as I said earlier, shame on us if we don't seize this.
What we've done is we've taken the core of the one-on-one personalized engagement and we've layered on the technology that's available, decision support algorithms that take in data at scale from continuous glucose monitors and make recommendations of dosing and titration adjustments. And we've set up a legal infrastructure that now we have a nationwide network of licensed endocrinologists where we can engage the whole patient. And this is a phenomenal innovation, and it's a phenomenal way to solve for the huge tsunami of patients that are coming our way with diabetes.
I truly believe our care model has to change and should change. And it should include a combination of remote and in-person visits tailored to the individual's needs. I think that would be optimal. One size does not fit all. We definitely should continue to use telemedicine. It's very efficient. So we need to be able to address all those. We need to be able to use remote and in-person when needed. And that should be part of our future diabetes care model. Our patients' comments for people who have interacted with the remote diabetes education, most of them have expressed a lot of gratitude, and they were overwhelmingly positive. Even people who've had diabetes for a long time, they had new insights, they received helpful suggestions. So my hope is that insurers will continue to pay for these remote visits. Like, we can't go back, please. We really don't want to go backwards.
What I'm hearing today is really exciting. I think it is going to be how we leverage telemedicine from our perspective going forward. Yes, telemedicine is here to stay. Yes, payers want it. I would say that for post-COVID, which will be with us for a while, I think our vision is that, our members continue to have access to these valuable resources that you. One reason that we partnered with Cecilia Health, it's one of the first community-based organizations that we did partner with, is because of access to CDEs. We saw that there were many of our members who couldn't access CDEs, especially through their community. Now, over the years, as Cecilia Health has evolved its thinking and we are with them on this journey, a provider like Cecilia Health is embedded in our network system. They now have access to all of those resources as well. So they don't have to say, Health First, may I refer someone for, this particular social need? They now have access to everything we have access